welcome to On Becoming a Healer. One day, back in the 1990s, I remember calling my co-host for this podcast, Saul Wiener. Of course, we didn't have a podcast back then. The reason I called is because I was beside myself, upset in advance about an upcoming visit with a patient who routinely got upset with me. In fact, I wasn't just upset about one visit, I was upset in advance about every visit. This is a woman on high-dose medications that were sedating, all kinds of medications, such that she would fall asleep in the office, and then she'd wake up just long enough to tell me that by reducing the doses of those medicines, I was doing immense harm and that I was a bad doctor. And I just felt defensive and just generally upset with myself. And as it turns out, I'm not the only doctor who has had feelings like that before visits with patients or after. The guest we're going to speak with today has spent over 20 years making sense of the clinician's experience of what may be called difficult encounters or difficult patients. It turns out to be something that happens in 1 in 6 or 7 ambulatory care encounters. But before I say more, let me say hello to my co-host, Saul Wiener. Hi, Saul.
Hi, Stefan.
So, Saul, tell me why you thought this topic could be resonant for our audience.
Well, when physicians talk about difficult patients, the conversation often becomes about what's wrong with the patient. Uh, that they're demanding, they're angry, they're manipulative, they're non-compliant. And one of the things that drew me to our guest's work is that it points in a somewhat different direction. His research certainly identifies patient characteristics that are associated with difficult encounters, but as we'll learn, the role of the physician in whether an encounter is difficult or not, or a patient is difficult or not, turns out to be really really large. That when we call a patient difficult, it may in some cases say more about us than it does about the patient. And I've found over the years that physicians respond to challenging patients in one of two ways. Either we pull back and hold them at arm's length, kind of this icy cold professionalism, or we become very reactive and start trying to kind of control the encounter to control them. And both of those responses make things worse. So, what I'm hoping we can do today is, first of all, hear from somebody who's looked at this issue empirically in a very rigorous way from multiple vantage points using a variety of data sources. And and once we've kind of done that and established what the data shows, maybe also talk a little bit about what we can learn from this data about ourselves as physicians and perhaps what we could be doing differently.
Our guest today is Dr. Jeff Jackson. Hi, Jeff.
Hey, how you doing?
Good. I'm going to say a few words about you. Dr. Jackson is a professor in the Medical College of Wisconsin, former editor-in-chief of the Journal of General Internal Medicine, and the leading researcher on difficult patient encounters in primary care and internal medicine. In over 20 years, working with collaborators, he has produced many papers on this topic using data from ambulatory clinics, from inpatient wards, including some work that involves recording visits, randomized trials, systematic review. And the core question running through all of this has been, why do some physician-patient interactions go wrong? What predicts that? What can be done? And he tends to get all kinds of data, both from the physicians and from the patients, to make sense of this challenging situation. First of all, just tell me a little bit, how did you get into this subject? Why did this draw your attention at all?
Most researchers get into things because they were pushed in that direction by their mentor.
Hmm.
And so my fellowship project was looking at patients presenting to an urgent care clinic. Basically, what we did was we assessed whether the patients had anxiety or depression using the PHQ-9 and the GED-7, and then fed back that information to the providers. And one of the things that my mentor was interested in determining was whether or not that might reduce difficulty. One of the co-investigators on the PRIME-MD study did a lot of work, and it's Steve Hahn. In fact, he created the DDPRQ, the difficult doctor-patient relationship questionnaire. It's 10 questions that has been used in innumerable studies now to assess difficulty for outpatient doctors. It hasn't been used in the inpatient setting. The study was like every outcome we could possibly think of, we measured, and nothing changed except difficulty. The primary care providers, when they were told that this urgent care patient actually had an underlying mental disorder, depression or anxiety, they rated the encounters as being less difficult. And I thought, well, that's interesting, and it's sort of led to a whole series of studies that I've done subsequently.
So, just for people who might not have caught that, there were two brief assessments mentioned in passing, one related to anxiety and the other related to depression. And we don't need to say more about them. But the point is that this was a situation where doctors could learn simply if the patient had one of these challenges. And I'm really actually sort of surprised that knowing somebody has anxiety or depression would make the visit feel it's easier to the doctor. Is that what I'm hearing was the case?
Yeah, I mean, the doctors filled out the 10-question difficult doctor-patient relationship questionnaire, and there was a pretty dramatic reduction in the percentage of patients that were experienced as difficult.
If it's okay, I'd like to ask if you yourself have had experiences with the care of patients which you thought, "Oh my gosh, this was difficult for me." And can you, without revealing any identifiers, can you describe what
Oh,
one of those
yeah,
might have been?
there is not a I don't believe that there is a single primary care physician practicing anywhere in the world who doesn't occasionally look at the list of the patients they're going to see that day and their heart sinks. That's what the British call it when they see the patient on their register for that day. That their heart sinks when they know that they're going to have to deal with Mr. Smith or Mr. Jones. So yeah, it's not unique. And I wish that my vast experience and research made me better at managing those patients. I struggle with them. I go home, talk to my wife. I wonder why I didn't do better. Why am I a bad doctor that I can't seem to make the encounter work? So,
So you're
it's a universal phenomenon.
you're in there with us, I guess, in this sort of challenge.
Oh yeah.
So, so one of the things that I in speaking about this, I really struggle with whether we're speaking about quote unquote difficult patients or difficult encounters. I notice you've switched the terms that you use in your own writing. What are the upsides or the downsides of speaking of patients as difficult? It seems very pejorative, doesn't it?
Very. That's why, and I slip all the time and call them difficult patients. And I actually have my wife review every paper I'm sending out now to make sure that I've scrubbed it to where I'm not calling the patients difficult. It's the encounter that's difficult. And when the measures that you get from the patients themselves after an encounter that the physician experiences difficult, they're not coming out unscathed. The patients have lower levels of trust and satisfaction with the providers who are also experiencing the encounter as difficult. So it's a two-way street. I mean, obviously, patient-doctor encounters are unbelievably intimate. They really are. I mean, I can ask patients questions, and I train my residents to ask those questions that you couldn't ask someone at a dinner party, or if even sometimes you'd be worried about asking your wife some of these, intimate questions about. So, the patients are sensing that things aren't going well.
I wonder if we could give me a sec just here. I wanted to pull up one of the DDPRQ items. How frustrating do you find this patient? Wait for this. Some people who know me know I hate this term, but just a little trigger alert. How manipulative is this patient? How much do you dislike this patient? Do you have others on that scale that you want to mention?
My favorite, and anytime I'm presenting anywhere, I always mention this one because it brings a nervous chuckle from the audience. You know, do you secretly hope you'll never see this patient again?
My God. Wow.
Yeah, yeah. I mean, that says it all.
And certainly there was a period in time, particularly early in my career, and particularly when I was calling Saul back in the 90s, where I remember sort of wondering, I just wonder if this patient will go away. So tell us now, based on some of the work you've done assessing the physician side, let's start with that. What kinds of what kinds of doctors have the greatest tendency to experience patient encounters as difficult patient encounters?
In general, inexperienced physicians. So the more years that the physician hasn't practiced, the fewer of their encounters they will experience as difficult, even if those encounters are new encounters. That is, say, urgent care. The other kind of physician that really struggles is the doctors who are really locked into the biomedical model. We're going to find your problem. We're going to fix your problem. It's biological. Bend the fortune, do every test known to man. We're going to fix this for you. But if you have someone who has somatization disorder, or they're having physical symptoms of manifestation of their underlying depression or anxiety, or they have chronic pain, or they have personality disorder, it's just not going to work very well to fix the patient. You're going to have to figure out a way to help them to come to a better place in dealing with their symptoms and not expect a cure. That's the mantra for chronic pain. If you're going to get someone's chronic pain to zero, it's just never going to happen, and you're going to be dissatisfied, and so is the patient. The goal is to get, obviously, your chronic pain patient to learn to function, to live with the pain, and then do your best to try to modulate the pain as much as possible. It's interesting to me is that, if you look at several studies have looked at complex patients, and I mean, like, for example, inpatients with really high comorbidity indices, or outpatients who have high, lots of comorbid conditions and a lot of medications. Those are not the ones that the providers are finding difficult, or even patients in difficult situations, a wife with Alzheimer's, or that you just made a diagnosis of cancer and you're dealing with that. Those are not the patients that doctors are experiencing as difficult. It's basically the list of patients I just gave you.
Yeah. And there's a survey you issued called the Doctor Belief Scale, and I'll mention a couple of the items where it sounds like if people agree with this, and I just want you to comment on a few of these, that tends to suggest the doctor's going to generally have more difficulty. If they say exploring psychological issues with the patient often causes me pain, that was one of the ones which sort of seemed to align with the doctor who would have more difficult encounters. Is that right?
Yeah, well, I mean, the Ashworth scale, or the doctor's belief scale, is pretty old. It,
Okay,
it
that's
was
not one you developed.
No, no, no,
No, no.
no. And it was created like in the 1950s, and so that's where most doctors are mostly practicing the Marcus Welby type of approach. So yeah, I think that most doctors that are going into primary care either get out or don't go into primary care at all if they're not at least somewhat biopsychosocially oriented, because we're not mechanics. We're not just going to be able to fix things. And I think that's what causes some of our colleagues to go into specialties. In addition to love of whatever that field is, there's a component of it's something I can fix.
So I'm going to offer you a quote from a doctor who was actually working in a hospital and ask you how we could help this kind of doctor. And the quote is from a study you published in 2024. The doctor says, sometimes we have to limit our empathy in order to preserve our own energy and ability to care for patients every day. Because if you fully 100% empathize with every single patient, you would be just so burnt out. First of all, does that sound right to you? I mean, can I
I
say it to
mean,
myself each morning?
well, I mean, I'm constantly having to remind my residents that the patient is the one with the disease,
Yes.
the, not you. And you do your best. You, you feel terrible for whatever situation they're in, what horrible disease they may have. But ultimately, you may not be able to help them other than just, be there for them and try to live through the experience with them.
That means there's a little bit of separation between you and the patient. But this particular hospitalist quote, it doesn't sound like they're all wrong when they say they have to not 100% empathize. But at the same time, I'm a little suspicious of the quote.
I, in my own mind, I think you probably feel the same way. Empathy to me is different than it's a different concept. So and sometimes what helps me with some of my really difficult patients, the encounters that I'm experiencing as difficult, is to try to empathize with them. I mean, whatever is driving them to make you feel uncomfortable is probably there in most of their relationships. My personality disorder patients, they come in and they start yelling at me, and if they push the right trigger, I don't yell back, but I may raise my voice and be a little bit gruff with them. I regret it for days. I lose sleep at night over it. But they don't seem to be plussed by that. And somebody told me once, well, the reason they're not plussed by that is because that's how everybody treats them. And that you're probably much more benign in raising your voice or being gruff. than what they experience on coming into the parking garage in the morning. That's the way that they interact with people.
I'll confess I lost it with the patient that I described early at the beginning of this episode, because I think we were in the middle of reducing doses of either benzodiazepines or opioids, and she said, "You're just trying to, you're just trying to ruin me. You're just trying to kill me." And I said, "Do you really think that every day when I come into work, I'm just trying to make your life worse?" Like that, almost that loud. And she
Yeah.
she cracked a smile and she said, "No, not really." And I think
Something that
that's what led to all Saul.
one of the studies that I recently published, it was the study where I was asking the primary care doctors who were taking care of the patients who were experienced as difficult in the inpatient setting, did they also find them difficult in their encounters in their clinic? One of the doctors, actually, one of the more experienced doctors, actually suggests, Jeff, you should add a question to your survey. Was he wanted me to add the question, if not, did you used to? And how long did it take before you no longer found them to be difficult? And because he said in his own experience, there's been many patients when he first meets them, it's just a nightmare. They, it's just every time they see them, he just breaks into a sweat knowing he's going to have to see them. And afterwards, he's searching his own soul to try to figure out why things didn't go better. But over time, you begin to develop a relationship and you kind of figure out how to coexist. And like the woman who smiled and said, "Well, no, I don't really think that you're trying to kill me or make my life miserable." I think that they keep coming back to you, so they must trust you to some
She
degree.
did.
And that some of those initially difficult encounters can actually prove to be the most delightful patients once you figure out how to work with them. Meet them in their place and try to. And so that's where I get a little bit nervous about 100% empathy. I think I 100% empathize even with my patients who I never want to see again. I really feel badly for them, but I try not to make it my problem. I can empathize, but still have that wall between me and them that protects me. We just created an instrument with the inpatient setting that's comparable to the DDPRQ-10, except it's going to be the DDPRQ-10/Is. And what really interested me was that the characteristics, the questions that the hospitalists responded to that marked a difficult patient actually had to do, a lot of the questions, even more so than in the outpatient setting, had to do with the harm that the physician perceived that they were experiencing as a consequence of interacting with the patient, that they felt that they were having some moral harm to themselves
Hmm.
because of the interaction with the patient. The
What is that?
outpatients, there's a couple of questions like that in the DDPR-10, but the instrument we came up with had more of those questions in the inpatient setting.
Can you
That
give me an
that seems
example
to
of what a
be
moral harm might be? Take a moment if you need to check it out, but I'm really curious what a moral harm feeling might be.
well. Actually, the question asked the one of the questions asked the providers to rate on a scale of never to nearly every time. How much harm do you experience as a consequence of interacting with this patient?
Wow, it's straight up. I feel harmed.
I feel harmed. I actually feel damaged as a consequence of interacting with this patient. I I, I can definitely empathize. There's definitely been some patients where I dread seeing them. It doesn't go well. I think about them for days. Is that harm? Yeah, it's interrupting my sleep. I probably would be. You could call it harm, I guess. I don't think that the outpatient doctors think about it like that, but the hospitalists were definitely keyed into that as a marker of a difficult inpatient.
Can you also, I want to ask, we've talked a lot the doctor's experience. Can you tell me a little bit more about your interrogation or your studies of the patient's experience of those same encounters? Are there, we know that patients experience some doctors much better than others and much worse than others, but is there a correlation where when the you hinted at this, that when the doctor's feeling overwhelmed or that this was challenging, the patient's feeling poorly served? What do you
Yeah.
have more insight on that?
Yeah, it's interesting. And if you're really going to look at that, you have to move, at least in the outpatient setting, you really have to move to urgent care visits because established patient-doctor dyads, the patients will almost always say that they're fully satisfied. The doctors at this hospital, completely horrible doctors, but not mine. My doctor's a great doctor. He's the zebra in the crowd. I wouldn't see anybody else in this facility but my doctor's great. And that's where we looked at it in the urgent care setting because these were not established patient-doctor dyads. And we saw a very strong correlation between the intensity of the rating. The rating on the DDPRQ is 10 to 60, with 30 or higher being a marker of a difficult patient. There was a very nice correlation between the just dichotomically cutting yes, no, the patient was experienced as difficult, and then also the severity of the difficulty. There's a correlation between that and the rating of satisfaction that the patient gave. So the more difficult the encounter was, the more dissatisfied, the lower the scale of trust was from the patient. And both satisfaction and trust are good markers for patients who are going to seek another doctor. And I think that's why it's difficult to study this in established patient doctor dyads, because patients, they have a choice. They don't have to come back to see you. And even if the first visit is really horrible, they definitely won't be back. In the VA, they'll march down to the patient rep's office and
Yeah.
write to their congressman and,
And I love that,
everybody
by
they
the
can
way.
think of. Well, yeah, no, the patient rep office actually at the VA works pretty well. They're used to people coming in and screaming. They're able to cool things down. And they also don't call me up and say, "Oh my God, Jeff, you're the most horrible doctor that ever lived. I had a patient come in." They know there's two sides to this story. And that's oftentimes hopefully the patient didn't record me yelling at them.
Yeah,
That'd
and
be kind of
I'll
hard to deny.
and I'll say, even we're not speaking officially for VA, but I also work in the VA context, and I'm actually a strong proponent of patient complaints. I think they can often just lead to a better understanding of what I'm doing or what we can do. So I've typically, when a veteran has said I want to complain, I've said, oh, you know what, that actually might help. It could be a good thing. I think it might be the time to call in my co-host Saul Wiener to ask, how do you think about the same question, Saul, of what are we to make? Is there some sticky issues raised by this discussion we should get to, and how would we do better?
I'm going to start with the premise that if you decide to become a doctor and not an engineer, for instance, you're caring for people, not machines, and people are complicated. And when they come to us with illness, they come with all the baggage of their life, all the baggage of their personalities, and our job is to accept that all of that is part of the illness experience. And so, by definition, when we say, oh, this patient is difficult and I hope they don't come back, I mean, we may not say that out loud. In a sense, that in itself represents a kind of failure on our part. Now, I'm not saying there aren't extreme examples. If a person's waving a knife in front of you, obviously that's not okay. But we're not talking about that for the most part. One thing that that I thought was interesting about Jeff's data is in at least one study in which he used something called the physician belief scale, which is an instrument that physicians complete, which allows you to get an assessment. We talked a little bit about this earlier about their psychosocial attitude, and he sorted two groups: those who had a poorer psychosocial attitude and sort of more biomedical orientation, and those are the ones who had a score of above 70, and then those who had a score below 70. And in this particular study, 45% of physicians had a so-called bad score, in other words, a poor psychosocial attitude. And what was very striking is that that group of physicians rated 23% of their encounters as difficult, whereas the ones who had the better score rated only 8% of their encounters as
Wow.
difficult. A very dramatic difference. And so I think what that showed, and he calculated an odds ratio of 3.9. In other words, the variable that was so big in whether a patient was, quote, considered difficult was actually the physician, not the patient. And that really resonated for me. You may recall that the very, very first episode that we ever did with this podcast, and
I recall this.
yeah,
Yes, me.
it was in September of 2020, was about a difficult patient. And it was about a guy we called Arthur. And he was in his late 20s. He had sickle cell disease. And he needed chelation therapy. He was really building up a lot of iron deposition, which was becoming life threatening. And his doctors had just basically written him off. They were so fed up with him. and his sort of, quote, demanding, manipulative nature, that they had said that he really wasn't a candidate for this intensive therapy. And it turned out that when he got a different doctor, he actually became a different patient. And he became somebody who actually could be quite, who was absolutely capable of participating in his care. But at that point, it was tragically too late. The accumulation of iron in his heart in particular, but also in some of the other organs, had gotten to the point of no return, and he died. He died before the age of 30, and it was a reminder of the potentially catastrophic consequences in this case of, quote, labeling a patient as difficult, quote, writing them off. And now, of course, not all cases are that extreme, but it shows how big the stakes are when we see patients in this regard. I think that there is still a lot of there's a lot to learn about what we as physicians could do better. It's a much harder thing to study empirically. I have my own theoretical idea about what a good healing interaction consists of. And I've mentioned it has to do with the ability to remain engaged with patients, even when they are, quote, triggering you, making you want to be avoidant, but not to need to pull back. But in order to do that, you have to have a clear sense of personal boundaries. And I think, as I mentioned at the beginning, what happens in these dynamics is that physicians develop this kind of icy professionalism that become very guarded with patients in this situation, or they become very emotive and angry. And both of those are negative, and ultimately can also affect the kind of service that they provide to the patient. But I'd like to talk a little bit more from Jeff's perspective about the physician side of this, and what you've learned, and what your thoughts are about this gap between the physicians who seem to judge almost a quarter of their patients as being difficult versus, I think, a more normal number, a more typical number, which may be more around the 7 or 8%.
I think the first thing that we need to do as physicians is to forgive ourselves. We hold ourselves to a very high standard. And when we have a patient that triggers us or that we just are experiencing as difficult, I think just knowing that we're not alone. Dr. Groves wrote the first paper on this in the New England Journal in 1978. I was actually surprised when I looked it up the other day that it was 1978, not 1958, that the first paper that came out on this topic. And he got a lot of flack from that. Many people said, "Kudos! This has been in the closet too long. I'm glad somebody's letting us talk about this." But he also got an awful lot of vitriol. What is wrong with you as a human being? You're a doctor. You're serve all, love all mantra. But I think that the next step that we should do once we recognize that we're in a difficult encounter is to take a deep breath and step back and try to diagnose what is it in me that's causing this encounter to be difficult, and then what is it that about the patient that is causing me to experience them as difficult. And if you can diagnose or recognize that what you're dealing with is a person with personality disorder, cluster B in particular, okay, there are well-known ways to manage patients with personality disorders at work. Same thing with, okay, they have underlying depression, they have underlying anxiety. Now that we're universally screening for depression and anxiety, it's less likely that it's going to be unexpected. Chronic pain, there's a whole literature about that. Bob Smith of Michigan State has done lots of work on medically unexplained symptoms. The guy who created the DDPRQ, Steve Hahn, he has courses at where he's at on how to manage patients who are making you feel difficult, giving the learners a script that they can use instead of just freaking out and getting all upset. And because obviously when you're having emotional responses to the patient, that's a part of the brain you don't want to be in at the time that you're trying to help them with their problem. You need to be in a different part of the brain, not down in the alligator part of your brain, to try to help the patient with whatever problem they're coming to see you with. Mac Lipkin had a course he taught for the longest time in New York where he was teaching residents basically how to manage. He was focusing on medically unexplained symptoms, but it's kind of all the same. It's an approach to help you to manage patients that you're experiencing as difficult.
So let me just to focus in on one of those first. People may have heard the expression cluster B, and I'll mention that includes antisocial personality, somebody who may show very little respect toward others or not follow expected rules. The term borderline personality disorder certainly lies in that cluster. Sometimes narcissism, extreme narcissism. These things can be provocative and difficult for many of us, particularly because they can involve somebody saying, you're the worst, you're actually terrible, or, F you. I
Yeah.
remember somebody screaming at me.
Yeah.
A veteran screamed at me and said, "You are a redneck," like really loud. And that is not me, but I remember thinking, wow, that's a lot of
Redneck isn't the term I'd use to describe you. I give you
no,
that.
I was thinking I'm a Jewish guy in a bow tie. This is a little odd, but it was loud and people noticed. So could you remind us or tell us a little bit about what our approach is to think about with our own mentality when we're seeing
Well,
somebody who
one of
has
the
in this
things that I
cluster
think we
B?
should all be real careful about is watching out for those labels. So you mentioned it
Oh,
earlier.
okay. Yeah.
A lot of my patients would come to me and in the chart it says borderline personality disorder. And then when I started interacting with them, I'm really skeptical that this person actually has a borderline personality disorder. Somebody had a
An
terrible
unpleasant
experience
day.
with them and put it in the chart. Now it's kind of following them around. I definitely have some borderline personality disorder patients who I have to use all my skills and rarely succeed.
Okay.
But they
So
keep
the
coming
label's
back.
a problem
So
by itself. Okay.
they can be harmful. So, we doctors talk amongst each other. And I had one of my colleagues say, "Hey, I'm sorry, I just can't take this patient anymore. He's transferring. I noticed he's been put in your panel and you're going to be seeing him on Wednesday." And I honestly wish that that doctor hadn't said anything because I didn't, you can't help but go in with a little bit of a, okay, this is going to be bad, anticipatory, and he turned out to be maybe just a better fit for my personality than this. Maybe he was just on his good behaviors. It may take a little while for the other behaviors to emerge. I don't know, but so the first thing you do is just take a breath, try to stay in your frontal cortex and not let the alligator part of your brain take over, and try to figure out, well, why, what is causing this encounter to be difficult for me. And most of the time you'll be able to figure it out, what's causing the, and if you've had experience, you've had training, then you can just flip over to that script. Like somebody comes in to see me with chest pain immediately. And of course, I'm looking at him, he's 50, late 50s, he's obese, he smells like cigarettes. So I'm thinking immediately, I'm worried about, well, what could be bad things that can cause chest pain in a 56-year-old man. And I immediately go down a script. And it's just a script. It's something that I've learned over the years that I follow. Do I think this is a coronary problem? Do I think it's acute? Do I think it's chronic? Where are we? What is he taking now? Et cetera, et cetera. It's the same thing with the difficult patient. One of the things I love about outpatient medicine as opposed to inpatient medicine is we have the luxury of time. Now, I don't mean time in our visits. We have very short visits, which can make it very difficult to get a lot done in 20 minutes or 30 minutes, however much you have. But if you're trying to establish a longitudinal relationship with a patient, and you're hopefully going to have a commitment that's going to last years, and you're not going to figure them out necessarily in one visit. I mean, in the first visit, you may be trying to figure out, oh, is this something terrible? Is he about to have a heart attack? Is he having a PE? Do I need to? But most of the time, when you're seeing him in the outpatient setting, that's not what's going on. And so you can try to use time as your ally and enlist the patient as a partner in the relationship. Most of the patients who doctors experience as difficult do not like, they feel a loss of control. And, providers are taught to be in control. I'm in control of this encounter. I've got 20 minutes. I can't linger too long on this, that, or the other. Sometimes with these patients, you just kind of have to let go of the control part. Know that you're only going to get a tenth of your agenda or none of your agenda that you had coming into the encounter done today. But you can always see them back, or call them up on the phone, or do a video visit. Whatever it needs to do. And then sometimes I remember vividly, I had a patient come in and spent the whole 30 minutes yelling at me how terrible doctors were. He's had 100. Literally, he said he had 187 surgeries. not true, but that's what he said. And that nobody can do his pain. And he spent literally 30 minutes just screaming at me. First time I had seen him, he had his chart that was like really thick, and I hadn't really had time to wade through. And so at the end of that time, I said, "Tell you what, why don't we strike a deal here? I haven't had a chance to really dig through this chart. You're very complicated. Why don't we plan on having you come back and see me on Tuesday? This is a Friday. I'll see you on Tuesday." And he came back on Tuesday, and he started on the same tirade. I said, no. I spent a half an hour last time letting you yell at me, but we have to have a different relationship if this is going to work. And it worked. And it worked for him in that particular encounter. And we developed a working relationship. He's not my favorite patient in the world, but he's not. My heart doesn't sink. It sinks a little bit, but not tremendously when I see his name on the register, because I know it's not going to be. He's just got a lot of psychosocial issues, chronic pain. He's got underlying depression, which he doesn't want anybody to treat because it's not my head, doc. I've really got pain. We primary care providers, you know the type, but you do your best.
Saul, do you have advice for us?
Well,
Yeah.
I think Jeff has said a lot of things that are wise, and I just want to emphasize a few of them and bring them out. So first of all, he talked earlier about the alligator part of our brain and the frontal part of our brain, and being able to understand what's happening inside ourselves when we react to a patient. And I think actually that's critical, but I actually think a lot of us are not very good at that, particularly when we get worked up. And so I do think that's what I consider to be boundary clarity. Boundary clarity is knowing what is you versus what's me. So in other words, when you're with a patient and you're starting to feel a lot of strong stuff, you're able to say to yourself, this is just my mishigas. This is my issues. I'm not going to let it drive what's going to happen in terms of the way I interact with this person. And the ability to do that, I think, is what he's referring to. And that's actually something that is actually not that easy to do. And that is boundary clarity. And I think what happens is when people don't have that ability, their reaction is, as I said, either to just hold the patient at arm's length to protect themselves because they don't like the emotions they're experiencing, or to basically vent back, which is probably even worse because it's anti-therapeutic. So that's the first thing. So that ability to do that, to say, this is me, that's you, I can separate, that is one thing. The second thing that Jeff said I think is really important is he said, is to let go of control. And I think that is another thing. And just as Jeff said, I think we have this strong need to we're very conscientious as doctors. We want to tie the visit up with a bow, and basically saying, okay, well, that's just not necessarily something that is going to happen today. And I think one thing I will sometimes do, I found a lot of residents feel like they don't know what to do when a patient just keeps talking endlessly or starts venting endlessly. And I think one thing you can do is you can interrupt a patient and say, hey, I just want you to know that unfortunately we only have 20 minutes today, and then I'll have to see another patient. So I'm hoping we can cover some other things. And so you're just kind of giving the patient a warning, basically, that the clock is ticking. And I find that a lot of times patients will stop venting when you say that, because they'll realize, oh my goodness, yes, the clock is ticking. And so, but you're giving them fair warning. So you're not waiting until they vented for 20 minutes and just saying, sorry, the visit's over. You're giving them fair warning at the beginning and just say, basically, if you keep doing this, we're going to hit a point where the visit's over. And so they're, at least you've given them fair notice. So I think that's another thing that's very helpful. And I think that the other part of this is that in return, don't pull back. Continue to be present, continue to be yourself with the patient. That becomes much easier to do if you're able to do these two other things that Jeff has said. One is to be able to manage your own emotions and keep those out of it. And the other is, as I said, not to feel like you have to tie the visit up with a bow, that you're there for this patient. I also think one thing that's so important is just not to be judgmental, to recognize that these patients have a lot of history. For example, all three of us have cared for veterans, and a lot of these vets have been through hell and back, or maybe not back. There's a reason
They're still in it sometimes.
they're still in it, right? There's so much they have experienced in life that we don't know about, or that we've never experienced, and just like understanding, that this is just part of the package. It's part of who they are and what they bring to you, and to just feel some love for that. This is just and as Jeff said, he feels badly, which is understandable. You would feel badly for these people, and to me that's a very healthy way to feel, because these people are suffering, and that's very different from just feeling angry at them, right? But I do think that these things are easier said than done, and I think that a lot of physicians do tend to just, quote, write these patients off. just have just a negative reaction towards them, and that's it. And it doesn't go beyond that. And I think that's sad. That's a failure on our part. It's a failure that we're not understanding what it is to be a physician, and we haven't grown enough as individuals to be able to have that boundary clarity. And I think that's where, and maybe that's something that needs to be talked about more when we develop physicians in medical school.
Certainly, figuring out where the boundaries are. And I think that staying present, being part of the patient's lives and being part of the patient's solution rather than get another part of the problem that the patient is having. That previous study where I actually added that question to the survey, we didn't publish it. The reason we didn't publish it because I'd already collected about a third of the data by the time that the doctors suggested it. But it was about 5%. 5% of the patients who the doctors rated as not difficult now, they did before, and it took
Before. Okay.
before, yeah, when they first started working with them, they experienced a patient as difficult. I took a mean of the number of years they said it took, and it was 2.5 years. So it showed that, you know, obviously the patient decides to come back to you. The patient decides to come back for 2.5 years. The patient must not be perceiving that you're not like Stefan, who's trying to just make his patient's life miserable. Um,
Yes, not
the
like me.
patient perceive that, you're really trying, you're doing your best. And that, most of the time, these patients who experience this difficult, it's not their first rodeo. You're not the first doctor that has been working with them. Oftentimes, you're the fifth, seventh, 10th doctor that they've come to looking for help. And it is nice when you can stay the course, help the patient, and then actually emerge at the end. Maybe they're not going to be in your top 10 patient list, but at least they're not the ones who you just absolutely dread when you see the name on the register. It is possible to work to a better place with these patients. And that's where I got a little uncomfortable when you talked about the hospitals was talking about, empathy. I think that empathy is the key ingredient to making these relationships work, because if the patient is triggering you, they probably triggered other providers as well, especially if you're the 10th provider that they've seen. And, the one thing that you can give them, if you have nothing else to give them, is empathy. Gosh, I'm sorry that this is your lived experience. I'm sorry that your pain is so severe that you can barely get out of bed in the morning. I'm sorry that you have no relationships. You have borderline personality disorder and you've driven everybody. I have one patient whose his own daughters and siblings will refuse to see him at all because he's so caustic. So he's difficult for me as well. But every time I see him, I think, I've got four sisters and a brother. What would it be like if I couldn't see his daughters won't let him interact with their grandkids? I mean, his lived experience is just miserable. And I think if I didn't, sometimes that's all I've got for him is that some empathy on my part about, I'm sorry that this is happening to you. I really feel badly.
Yeah, I think, and Stefan has heard me bring this up. It may sound like I'm nitpicking, but I often prefer the word caring in describing what you're describing over empathy. And it's a subtle difference, but empathy implies that I mean, again, people debate what these terms mean, but empathy implies that you know what they're feeling. But I think what you're really saying is you just care about them. You want the best for them. You can appreciate how brutal their situation is. For example, in the level of isolation that you just described, you
Yes.
actually have no idea what it is like to be them, but you care. And I think that caring is so important because once you start to care for a patient, then you're just thinking, what can I do here that might be helpful to this person, whatever it is, and that is it's wonderful when a doctor is thinking about their patient that way. They're just saying, how in the world can I be helpful to this person, if at all, and trying to find ways to do that, and that's what's driving you. And I think that's what you're getting at. And by the way, the answer might be nothing. But in some cases, there is something you can do, and that something may simply be being a steady presence for them over time. And I think you've described that. You've talked about how sometimes it can play out over years, but by being the only stable rock in that person's life, which sometimes I think the primary care doctor is, that can be invaluable for a patient, particularly a patient who lives in a world of chaos and dysfunction, to have a physician who they can come to, who doesn't judge them, who doesn't get into negative interactions with them, who remains present, but who also has clear boundaries and who says, "Look, I'm sorry, the visit's over," but who's a stable, steady force, who's that rock. I think that can be inherently therapeutic for a patient who is living with that kind of chaos and isolation that you're describing. That's where we as primary care doctors can be valuable, assuming that that's a role we're willing to play, and are capable of playing and can embrace. One of the things that's interesting is I've often asked my residents, what are the characteristics of the patients you most look forward to in clinic? And the most consistent response I get is, I really love the patients who essentially think I'm a great doc. I love the patients who appreciate all that I do for them. And I think that's great. It's totally understandable. But the thing is a lot of patients are just too grumpy and miserable and suffering to compliment their doctor and tell them how terrific they are. And so the problem is that if that's and inherently we're going to give more attention and be sort of give more love to the patients who we like. And if those are all, those are patients who are, well enough and capable enough to make us feel good. But honestly, a lot of our patients are just not that. And think about how unfortunate it is if that's a burden that we're, unwittingly putting on our patients, that they have to like make us feel good in order for us to be our best to them. And so one of the things I try to do is reframe it and say, look, how about instead that you get your sense of reward from seeing your patient do better over time, regardless of whether they show you appreciation? So if you can see that this patient is slowly over time, that their life is improving, that their functional capacity is changing over time, maybe they never thank you for it, but you see it happening, and that's your sense of satisfaction and reward. Then you become capable of finding joy in caring even for the difficult patients.
I really like that distinction you made between caring and empathy because I oftentimes, especially with chronic pain patients, will just say to them, I don't know what you're experiencing. I am lucky that I have, the usual pains that people get once in a while, but I don't ever have to take medicines on a chronic basis. And so I don't try to, empathize with them in the sense that I have any idea what they're going through.
Mm.
I don't trigger people right and left like patients with borderline personality disorder do. So I can't imagine what that would be like to be
Exactly.
constantly in chaos with every encounter you have, from the bank teller to the person at McDonald's drive-in. I don't know. So I think that's a really, really good distinction between the two. There's a whole literature on, delisting patients. When is it that you should decide to move them out of your clinic? The VA, we tend not to do that unless we absolutely have to, because we all know that we all have a certain percentage of our patients that we're experiencing as difficult. Hopefully, it's more like 8% and not like 25%. But I'm not unique in that situation. If I send one of my 8% to another provider, then I'm just added to their burden. But sometimes the relationship has gotten toxic on both sides, that the therapeutic relationship is broken. And I hate it when people actually put that in their consult to change patients at the VA, because I wonder if they just got frustrated with them, if the therapeutic, but sometimes the therapeutic relationship really is broken and it's time for them to develop a new one. I've had to do that in the last 10 years. I think I've done it with 3 patients, and I still tell you who they are and, their names and such, because it was hard. It was very hard. And I know 2 of them have been doing better with their when they went to another provider, because the 2 of us had worked ourselves into kind of a corner, and we couldn't quite figure out how to get out of our toxic relationship.
And what I hear there is a little bit of mercy or kindness for yourself in that situation, Jeff. And I certainly admire that. I think that was something you said at the very beginning of this conversation.
You commented that Jeff was showing mercy to himself, but I think there's something even deeper there, which is that he's also doing what's in the best interest of his patient. And I think that when we find ourselves in a situation where we're not able to provide a therapeutic relationship to a patient, we actually owe it to them to help them find a different doctor. It's important to know when that happens, and as Jeff says, hopefully it doesn't happen very often. But when it does happen, that we're actually acting in the patient's best interest. If there's nothing you can think of about your patient that you like, then they probably need it. You probably have to help them find another doctor. And I think that's hopefully that doesn't happen very often, but it does happen, and I think that's another part of looking out for the patient.
I I heard Saul mention something important there, which is about the concept of whether you can find something you might like about a patient. And I will mention the person who yelled at me and called me an effing redneck, I might say. I came to think that I admired the anger because the anger was he sort of spit fire at the nurse and me. And there was an opioid story, and my intention was to continue. I actually thought stopping them would be a bad idea. But I remember thinking, this anger is a survival skill. We can't have screaming in the clinic. That won't work. But I actually kind of like it at another level. I kind of realized it's worked for him. So I told him, I with the nurse present, I said, God gave you and in this case, I knew he was religious. I said, I think God gave you a powerful sense of anger, and I think that's a gift in a way. Now, we can't have you spitting fire at the nurse and the doctor when you come in, but we need to realize it's really important that you have that. It's just that when we see you, if it's on display full blast, we won't be able to figure out the medication stuff that we want to work through. Is that all right with you? And he kind of smiled, and he kind of came down to earth and said, okay, that works. But I have to admit, I wasn't faking it. I realized I kind of saw the anger as some kind of gift that he had, a problem, but a gift, and it helped me forward. I mentioned another case at the beginning of the person who I called Saul about in the late 1990s, and there was a boundary issue because I had grown up thinking that the part of the reason I wanted to be a doctor is to help people, and part of how I knew I was helping people is they told me, "Wow, you really helped me." And I talked to Saul about how insecure I felt about this patient. And he said, Stefan, your goal isn't to please the patient, it's to help them. And I suddenly realized there's a difference between seeing somebody tell you you've pleased them and the actual act of helping, which they may not recognize in that very second that you're doing it. And that my need to have somebody show on their face, I am so happy with you, that was my shit. That was my shit that I didn't need to introduce into the visit with the patient. And that was a boundary. That was the difference between something I was dumping into this overly sedated patient and what I could actually do, which was help, which doesn't always mean that they're going to say, hey, you're helping me right now. Thank you so much. And Saul, by the way, thank you for that 1996 advice you gave me.
Well, I think a
But
lot of people can identify with what you just said. I resonate with your comment about admiring the anger of your patient. We just interviewed another guest for a different episode that will precede this one, and he talked about the fact that he actually really enjoys caring for, quote, the difficult patient. And it was funny. It was so refreshing to hear him say that because I've always felt like a unicorn because I actually really enjoy that as well. And early on in my career, I did not feel that way. It was unnerving to me. I felt like the patients were ungrateful when they were kind of yelling and complaining about the food and so forth. And I was busting my butt to care for them. But at a certain point, I was just like, God bless you. Like you're letting it come out. I just like welcome that now, just because there's nothing suppressed. And obviously it can become challenging at times. It sounds perverse, but I
No,
kind of
not
love
at
it.
all. I mean, the guy, I was impressed exactly how long that guy was going to yell at me. At the SGIM meeting I just came back from, there was a workshop on managing the difficult patient. It was thoroughly enjoyable. And a lot of what they said is exactly what Saul was talking about: setting boundaries, working for a therapeutic relationship. Caring is the most important spice in the bouillabaisse that you're making, and time. So many of these patients have been abandoned by everybody else in their lives that, like Saul said, you're the one person that they can count on. Will see them and will not be nasty to them, and be empathetic and caring in your approach. That'll get you a long ways. And even experienced clinicians, the three of us didn't just finish residency last week. Not every clinic, but occasionally I'll have a patient who I have to take a step back. Okay, I'm in a difficult encounter. Take a breath. why am I experiencing this encounter as difficult? And I may not be able to figure it out in the setting, but I will look back through the chart a little more closely, maybe talk to the previous providers if they're available, to try to diagnose what the difficulty is that was causing the encounter to be difficult. And once you figure that out, then you just pull off the shelf the script for the person with borderline personality disorder, the patient with depression, the patient with chronic pain. But all those scripts have at their core this concept of caring. I may not be able to fix your pain, but I'm sure going to try my best to help you do the best that you can and live as good a life as you can with the pain, because I don't think we're going to be able to get the pain to completely go away. And these patients aren't dumb. They come in with the expectation, if you want to call it that. They will say their goal is to get the pain to go away, but they know that it's not going to. And so they're usually somewhat open to you're saying that to them, that
Yeah.
we're going to work together. And they're very open to the concept that I'm here for you. I'm going to be with you, and we'll work through this together, and we'll try to get you to the best place that we can.
I think that's all very well said. I think that on the one hand, we need our trainees to learn a set of skills, but at the same time, it can't just be a cookbook. That caring has to be there. And then the other point I would add is that it doesn't always end well. I think it's important to understand that there are some patients, their trust in themselves, in the world around them, and their providers has been so damaged, perhaps going way back into early life, that they're not going to be able to build a rapport with you, and that it isn't going to ever work. I think it's just important to recognize that does sometimes happen. That's the reality of it. But you are going to continue to be present. You're going to continue to be offered to be that rock, to be that caring physician, clinician. And that creates the best possibility, the best potential over time for them to begin to trust, to begin to engage with you in a way that's beneficial to them. But maybe not. You just don't know. But at least you continue to be the constant. You continue to be the caring clinician. And I think that's all we can do. And most of the time, that will lead to a therapeutic relationship, but not always.
Yeah. Wise words. Well, I want to say thank you to Jeff, to my co-host Saul, for a great conversation. And I hope that it is one that we continue and that our audience can draw from as they proceed to try to be healers, a topic we will return to again. Thank you.
Thank you, Jeff.
Thanks, guys. This was a lot of fun.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.